evaluation. You can find the link in the chat feature or in the Scientific Program tab on the Virtual Congress platform. Thank you.
Thank you for your kind introduction and welcome to the first session of this Congress. It's my honor to present about current management strategy for Parkinson's disease with early clinical signs. I'm going to talk from the motor aspects and being more likely to be a futuristic point of view. Here is my disclosure, and I have no conflict of interest. The objective of this session is to summarize the current management strategies for Parkinson's disease in the early clinical stages. I would highlight the three principal management goals in early Parkinson's disease. We can set a time frame for early clinical stage of PD between the motor symptom appearance and the beginning of motor fluctuations after years of treatment. In patients with this stage, an important treatment goal is an optimized control of Parkinsonian symptoms while modifying disease progression and delaying motor complications. Lastly, to maximize the therapeutic outcome at this stage, it is crucial to detect early Parkinsonian signs and be diagnosed early. Previous studies have shown early motor signs can be seen 5 to 6 years before clinical diagnosis. Therefore, if we capture those Parkinsonian signs earlier, we will be able to initiate a disease-modifying strategy early. As a result, we may expect to produce a better outcome in the future. From the autopsy data of the Honolulu Asia Aging Study cohort, subtle motor signs in the elderly are shown to be related to the Nigra cell loss. This study also reported insightful observation that the dorsolateral side of the Nigra is more likely to be affected with age-dependent pattern, so maybe non-specific to Parkinson's disease. However, the more specific signs of pathological Nigra degeneration are beyond this region. They may be associated with impaired speech, reduced facial expression, difficulty arising from the chair, and impaired leg agility. The similar regional specificity for a Nigra degeneration in the elderly cohort of US without Parkinson's disease consistently reported extra dorsolateral part of Nigra degeneration and is more likely to be a pathological neuronal loss. And this neural loss is connected to mild Parkinsonian signs in the elderly. In this study, Nigra neuronal loss is found in 1/3 of the cohort and Lewy bodies in 16.5%. Therefore, detecting subtle motor signs specific to Parkinson's disease pathology will lead us closer to diagnosing earlier stage Parkinson's disease. In the large population-based cohort in Netherlands and enriched high-risk IRBD cohort in Canada, motor symptom trajectories are well identified to being appeared around 4 years before a PD diagnosis. Therefore, we still need to develop a good way to diagnose earlier stage PD from the motor aspects itself. From the previous literature, features of aging not specific to Parkinson's disease, a broad-based shuffling gait, general slowness, not affecting dexterity, and quivering voice and unsteadiness with falls. In contrast, impaired dexterity and handwriting and lack of facial expression would suggest Parkinson's disease motor signs. The MDIS criteria for prodromal PD suggests the cutoff for motor signs of the MDS-UPDRS Part 3 score as 6, excluding action tremors. However, more sensitive measures detecting manual dexterity and subtle gait and balance problems have been increasingly investigated with technology-based and wearable systems. Subtle motor signs detected by wearable devices have been reported in several excellent papers in prodromal and early PD patients. Currently, further larger longitudinal cohort studies are needed to validate these technologies detecting subtle motor signs of Parkinson's disease. LAC2 and GBA mutation carriers enrolled in the PPMI study also have shown subtle signs scored in the MDS-UPDRS, although they reached far below the threshold suggested by the MDS prodromal Parkinson criteria. However, interestingly, both gene carrier groups scored higher than healthy controls, but the striatal DET imaging could not explain the scores. The longitudinal trajectory of subtle signs of Parkinsonism in these gene mutation cohorts would provide these findings true clinical significance. Disease-modifying strategy comes from the concept that if we restore dying cells in the brain or prolong the survival of neurons and block the propagation of the pathology, the results would be shown as changes in the disease course over time. Thus, early detection of earlier stage PD and starting disease-modifying therapy is ideal for Parkinson's disease patients in early stages. We are now approaching this goal much closer than before, but still have a long path remaining to accomplish this. There is an increasing number of clinical trials for early Parkinson's disease to investigate the potential disease-modifying effect. Therefore, let me pick up some of those strategies in this slide, but show the major promising targets with recent or ongoing clinical trials only. As you see here, the strategies are heading towards reducing alpha-synuclein aggregation and restoring mitochondrial and autophagic lysosomal function, reducing ion-mediated cell death, and reducing detrimental pacemaker-mediated signal. The net effect would be a restoration of dopaminergic cell function and more survival of neurons. I will not deal with the progress in immunotherapy development here because it will be presented in other sessions during this Congress. First, I would mention the glucagon-like peptide-1 receptor agonist trials, since it has been shown some promising results of lessening motor symptom progression in 2017. A subsequent analysis showed a persistent benefit in participants with longer follow-ups, and there is an enlightenment of the mechanism of action of this drug in the brain. So now 7 phase 2 and phase 3 trials with GLP-1 agonists or other anti-diabetic agents are undergoing in Europe, North America, and South Korea. After the first phase 2 trial, exenatide is now investigated with phase 3 trial in the UK. Most trials set the primary outcome by the MDS-UPDRS score change, but one trial in Sweden aim to analyze brain metabolic network change and include accelerometer-based activity measures. 3 trials include DAT imaging, and exenatide slow-release formulation is claimed to be more penetrant to the brain and in compared to once-weekly and every 2-week regimen in Korea. NLY-01 is a pegylated formulation, improving brain penetrance and selectivity. Of note, the other 3 peptides are shown to have greater efficacy in some points than exenatide in experimental animals. A disappointing but providing lessons to disease-modifying therapeutic development, the L-type calcium channel blocker isradipine large-scale phase 3 trial failed to slow Parkinsonian symptom progression in early PD. In addition, discussions arose with the lack of specificity of isradipine to target channel and the lack of biomarkers to show therapeutics target engagement, and the outcome measure setting may not be optimal to address this modification. There is increasing attention to the possible pathogenic role of LDL cholesterol in Parkinson's disease. This excellent figure made by Garcia-Sanz et al. Shows the intracellular trafficking of LDL cholesterol into the multilamellar bodies in dopaminergic neurons. The glucocerebrosidase and related lysosomal dysfunction increased the number of multivesicular endosomes containing cholesterols and pathologic aggregates. The investigators also suggested a hypothesis of transneuronal propagation of pathogenic alpha-synuclein through the cholesterol-triggered multilamellar bodies in Parkinson's disease. Epidemiological studies regarding the association between statin use and the development of Parkinson's disease have shown controversial results so far. However, the dosage of statin in clinical use might not be enough to reach the target in the brain. There have been 2 clinical trials used lipophilic statins in PD, and recently one with single-center small-scale double-blind controlled trial in Taiwan reported an exciting result. There was a tendency of improving off-epidermis mood symptom with lovastatin treatment, while the benefit wasn't maintained after washout. The fluorodopa uptake ratio showed an increasing trend with lovastatin, whereas decreasing with placebo. This finding is more likely to be reactive changes in enzymatic activity rather than a restoration, considering a reported annual exponential decay curve in the fluorodopa uptakes in Parkinson's disease. However, the consequence of this interesting change needs to be followed up by further longitudinal observation of this cohort. In the presence of excessive iron, there is increasing lipid peroxidation with or without low glutathione levels, which may finally induce neuronal network ferroptosis. Therefore, ion chelation has been proposed as a potential disease-modifying strategy in Parkinson's disease to restore this neuronal cell death pathway. A pilot controlled trial of deferriprone performed in the UK showed a tendency of lessening motor symptoms and improving ion signals in the dentate and caudate measured by ion-sensitive MRI. The results are not promising enough. However, ion and neuromelanin is the key pathological event of the substantia nigra cell degeneration. Therefore, by improving the ion measuring MRI techniques such as QSM, and using a more selective and brain-penetrant ion chelator, further trials are worth being conducted in a large multi-center setting. The outcome measure most commonly introduced in early PD trials is the changes in the MDS-UPDRS scores. However, the sensitivity of this measure and the long-duration symptomatic effect of levodopa are unresolved issues. Although the UPDRS measures are performed after 12-hour medication off, this long-duration symptomatic effect is often observed in early PD patients with a honeymoon period in early stages. More specific outcome measures such as biomarker-based and therapeutics mechanism-based model need to be investigated in future studies. Nevertheless, there will still be some concerns that arise if the clinical measures are not significant while imaging parameters are significant. So then, how do we interpret the results? This small single-arm trial of Ambroxol showed CSF marker changes supporting the target engagement of this drug as a glucocerebrosidase chaperone, enhancing the autophagy clearance of alpha-synuclein. A phase 2 double-blind placebo-controlled trial for Parkinson's disease dementia is ongoing in Canada. The MOVE-PD trial with a glucosylcerebromide synthase inhibitor